Carl, could you kind of introduce yourself and tell people a little bit about your practice and how you've come to this, and then I'll let you share your screen and take over.
Sure. Thanks for having me here. Have to say it's a little intimidating to be talking to a bunch of literature students. I majored in applied math and biology, not so much because I love the subject matter, but because I had an abject terror of writing papers. And that's taken me decades of psychotherapy to work out. But nonetheless, here I am. I practice emergency medicine. That's been the thing that I've done for 30 years. And a number of years ago, got introduced, or I should say reintroduced to psychedelics through a friend who was approaching it through a therapeutic lens, which was something that was new to me. For me, it had always been just something that was done for fun in the context that I think the paper that Patricia recently sent out talks about, the fun aspect of psychedelics. But, at the same time, it was somewhat, the experiences that I had were somewhat illuminating in a way. And the idea of using psychedelics therapeutically was intriguing. And I had a couple of experiences that were profoundly impactful to me and led me to pursue a certificate in psychedelic therapy and research that I got at the California Institute of Integral Studies, where I met a number of people with similar interests, and I wound up founding a clinic here in Northern California called Temino Center for Integrative Psychotherapy, where we practice psychedelic psychotherapy. Currently, the only legal psychedelic is ketamine, although we've been selected by the Multidisciplinary Association for Psychedelic Studies, MAPS, as one of their first 10 sites in the country to be able to provide MDMA-assisted psychotherapy for PTSD under an expanded access protocol that the FDA has approved. So that's a little bit about me, where I come to this, and I'm happy to share my experience. I've done a little talk that hopefully ties in, it has some touch points with what you all have been studying. And if there's areas that feel like they're too esoteric or tangential, feel free to redirect me. And at the end, I'm happy to answer any questions that you might have. What I've done is, rather than being a talking head for my time, I have some slides. So I'm going to talk a little bit about personal narrative and psychedelic therapy. Story. Story is what separates us from the pack. And I'm going to start with the book Sapiens by Yuval Noah Harari, which is pretty broad ranging. But one of the things that was really interesting to me is he posits that what separates early Homo sapiens from other competing species was the ability to create shared fictions. And in addition to the obvious shared fictions that early man and women had, such as creation myths, he points out that structures that we take for granted in modern life, like money or corporations, are themselves shared fictions. When you think about it, what intrinsic values do these funny green pieces of paper, at least the ones we use in the US, have? None, really. They are dependent on the idea of value that's held as a common belief, as a common fiction. Corporations, too, which in the States have been granted by Supreme Court rulings like Citizens United, the status of personhood, are similar fictions that we take for granted, and we don't see them for the fictions that they are. And it's that taking for granted the reality of these fictions, shared or otherwise, that we'll turn back to when we discuss the effects of psychedelic therapy in a bit. You see a quote from Sapiens here: the ability to transmit information about things that don't really exist, like tribal spirits, nations, limited liability companies, and human rights, led to cooperation between very large numbers of strangers and rapid innovation of social behavior. And those narratives allowed greater social cohesion, which allowed Homo sapiens rise to supremacy and the concomitant decline of competing hominid species, including Neanderthals. So in a sense, it's our story-making abilities or potential for narrative that are the reason why we're here today, talking about narrative on this video conferencing platform made by a company that is itself a kind of shared fiction, Zoom. And that's powerful stuff and sometimes hard to see for what's underneath it all, namely the stories that we tell ourselves and that we share with others. As a bit of an aside, Terence McKenna, as a psychedelic researcher, developed a theory called the stoned ape theory, where he posited that it was the discovery of psilocybin mushrooms that caused early hominids' primitive brains' information processing capabilities to rapidly reorganize, which kickstarted the evolution of cognition that led to art, language, and technology in our archaeological record. So where do our stories live? 4 billion years of evolution has left us at the top of the cognitive heap, so to speak, or at least close to it. Our brains have developed multiple layers over time, with the more primitive structures controlling automatic and primitive reflexes being overlaid by the cerebral neocortex, which is a structure that confers the ability for language, abstraction, planning, and perception. Patricia alluded to, and I think you may have read a bit about the default mode network. And the default mode network is a structure, or really a set of structures in our brain where our story gets played out. It's a hub of brain activity that links parts of the neocortex to these older structures that are involved in emotion and memory. So the default mode network is where our minds go to wander. We go there to daydream, to ruminate, and to time travel. And by time travel, I mean think about the past or think about the future. We reflect on ourselves in the default mode network. We worry there. We imagine others' mental states. What are they thinking about us? What do we think about them? What do we think they're thinking? And it's really the neural correlate of the construct of the self or the ego, or at least as close to it as we can find. So in short, the default mode network is where we create and act out our narratives. It's also where we interpret those narratives to create a sense of meaning for our lives. So where does consciousness live? Now that we've located ourselves in the default mode network, I want to digress for a minute to say that while there is no longer much controversy as to where the correlate or the self exists structurally in the brain, the issue of whether the self exists at all is far from settled. Chris Niebauer wrote a book called No Self, No Problem, How Neuropsychology is Catching Up to Buddhism. And he notes that the concept of the self is an illusion that's wholly created by the left side of our brains. And that tends to validate the inward-directed consciousness research, if you will, that Buddhists have been practicing for millennia. There's also significant controversy as to the nature of consciousness and how it arises. And most mainstream neuroscientists will tell you that our consciousness arises as an epiphenomenon. In other words, it arises as a result of our neural activity. And if you kill the brain, you kill consciousness. But there's another faction that believes that consciousness is primary stuff of the universe, just like matter. Just like matter, space, and time are primary stuff, and that our brains act more akin to a TV receiver channeling consciousness. And to look for consciousness inside the brain, they argue, would be like taking apart your Samsung flat screen to try to find the latest episode of Fleabag. And interestingly, the folks who support the consciousness as primary stuff hypothesis find evidence both from Eastern meditative practices as well as from the science of quantum mechanics. And I have a few references. There's a book called Mind Beyond Brain by a guy named David Presti, a book called An End to Upside Down Thinking by Mark Gober. The Tao of Physics is a classic by Fritjof Capra. The Self-Aware Universe by Amit Goswami, and I'm happy to share those references for anybody who's interested. Hungry brains. Our brains consume a huge amount of energy, and the default mode network consumes a disproportionate share of that energy. And that's relevant because it's really important for our brain to be able to take shortcuts where possible. over the course of human evolution, food, energy was much scarcer a resource than it is nowadays for most of us. So energy conservation carried huge evolutionary advantages. So our brains have evolved to become excellent at recognizing patterns in our sensory input and matching those patterns to our prior experience. But this is where we become victims of our evolutionary success in a way. The rapid pattern matching enables us to efficiently identify the predator animal in our visual field in very little time, and that clearly has survival and thus evolutionary advantages. We've avoided a potentially devastating negative experience due to our pattern matching experience, and we've saved a lot of energy in doing so. I'll talk a little bit about the overconstrained brain. So where the advantage of pattern matching, if you will, rapid pattern matching goes off the rails, or really maybe a more apt expression in this case is where it gets locked onto the rails or stuck in the ruts, is that our default mode networks pattern match, as we think about the world, a little too well. In other words, our experiences, especially negatively weighted experiences, get reinforced as patterns that we match to. Remember, avoiding negative experiences carries a survival advantage. So we're predisposed to an awareness of negativity, and neuroscientists call these biases of cognition overweighted priors. We overweight these prior experiences that we've had. So our stories about our past become locked into negatively weighted narratives on which we ruminate, and that gets encoded as depression. Life is shit, and I have lots of evidence to prove it. And then similarly, our projections into the future become colored by these negative overweighted priors, and this gets encoded as anxiety. Life is going to be shit, and I have lots of evidence to prove it. Our need to patrol the perimeter to keep ourselves safe, again, to see how this, you can see how this confers evolutionary advantage. When that's overactive, it becomes encoded in obsessive compulsive behavior. So in a sense, all three of these conditions, depression, anxiety, OCD, can be thought of manifestations of a brain that's overly constrained, where you can think of where our storylines, either about the past, the future, or the present, become locked in negative ruminative ruts from which we can't escape. Moving on, I'm going to talk a little bit about trauma, which is another area that we work in psychedelic therapy. In order to understand trauma, we have to understand how normal memory is encoded in the brain. I'm referred to a passage from Acid Test, Tom Schroeder's book, where he quotes neuroscientist Torsten Passy. Sensory input is, the information that we got from our eyes and ears, taste, all of that, routed through a brain structure called the thalamus, and that gets passed up to evolutionarily more recent higher brain structures, where that sensory input is sorted for context and assessed for significance. In other words, this is where we make meaning and assign meaning, and then that stuff is passed back to the thalamus and routed to the hippocampus, where it's encoded as memory. So the important thing to remember here is that under normal conditions, storage of memory is mediated by our thinking neocortex and our ability to assign meaning. In severely traumatic experiences, the neocortex is cut out of the loop, and the sensory information is passed directly from the thalamus to the hippocampus for storage. And so these raw memories get stored that are associated with all the kind of autonomic nervous system stimuli that accompanied them, this fight or flight response that when something horrible happens gets activated, and our heart rates go up and our blood pressure goes up, and we're petrified. And the brain senses these memories as a constant threat, and they come kind of crashing into our conscious awareness as uninvited flashbacks and memories and nightmares. And that is what the condition of PTSD or post-traumatic stress does. We have these horrific intrusive thoughts that appear out of nowhere. people who have severe PTSD have such severe intrusive memories that they're no longer able to function meaningfully. Current treatments are lousy. People commit suicide at very high rates. It's really a horrific illness. Psychedelics, I'll talk briefly about the different types of psychedelics. There are three kinds. There are classic psychedelics or tryptamines, of which psilocybin, NN-DMT, NN-DMT is the active ingredient in ayahuasca, mescaline, LSD, and 5-MeO-DMT are examples. They're all analogs, meaning they look a lot like the neurotransmitter serotonin or 5-hydroxytryptamine. And they look enough like serotonin that they bind to the sites in the brain that would otherwise be bound by our own serotonin molecules. So in other words, our serotonin receptors are fooled by these molecules into thinking they're serotonin. All of these molecules have a preference for one type of serotonin receptor called 5-HT2A, and that's the receptor that's thought to be responsible for the non-ordinary states of consciousness in psychedelic experience. Another class of psychedelics are the substituted phenethylamines, of which MDMA is really the only one you need to know about. They are all structurally related to the amphetamines, if you will. So MDMA stands for methylene dioxymethamphetamine. So it has amphetamine-like properties. They're also related to medicines that you probably have heard of, like pseudoephedrine or Sudafed, the antidepressant bupropion or Wellbutrin, some asthma drugs. These work in a slightly different way. They actually act to release our own serotonin, but they're called promiscuous drugs because they affect other neurotransmitters like norepinephrine, dopamine, oxytocin, etc. Ketamine is in its own class. It's purely synthetic. It works on a completely different neurotransmitter system called glutamate, glutamate being the most common neurotransmitter in our brain. Talk a little bit about characteristics of the psychedelic experience. Psychedelics are often called non-specific amplifiers of consciousness. One of the hallmarks of the psychedelic experience is suggestibility. And some people have suggested that it's this suggestibility in the psychedelic experience that's kind of the secret sauce in psychedelic therapy. There are visual alterations, and under certain circumstances, some people will have mystical experiences, which some people might say is also can be a key to the healing power of psychedelics. Moving on, have I had a mystical experience? Well, there's a questionnaire on the net if you want to take a look at that. 30 questions. The mystical experience questionnaire can determine whether you've actually had a mystical experience. There are certain qualities that are characteristic of it. It's mystical experiences are ineffable. They defy expression. They defy explanation. People get tripped up trying to explain what happened to them. They have a noetic quality, which means that you get an insight into depths of truth that are unplumbed by the normal discursive intellect. In other words, there's a sense of something that is profoundly true that was previously hidden being revealed. Mystical experiences are of their nature transient, but they seem to have persistent effects. And they're typically passive. People have mystical experiences not as active seekers, but as passive recipients of the mystical experience. A little aside, the difference between direct mystical experience versus religious dogma. Religious dogma, if you think of it, is an example of mystical experience by proxy. In other words, your prophets and your seers have the mystical experience, and then the fruits of that mystical experience are handed down as dogma, as religious truth. Talking a little bit about the indigenous and non-Western roots of psychedelic therapy. Psychedelic substances have been used by humans in ritual divination and healing for thousands of years. A shaman's bundle was discovered in southwestern Bolivia recently, containing ritual artifacts, including a decorated headband, llama or llama bone spatulas, carved tubes for inhaling substances, and a pouch that was fashioned from fox snouts. The pouch was radiocarbon dated to between 900 and 1170 AD and contained plant material with chemical traces of DMT and harmine, which are two of the active ingredients in ayahuasca. So the Shipibo people of Amazonia have been practicing ayahuasca shamanism for millennia. The photograph up is a petroglyph from northern Algeria dating to between 7,000 and 9,000 years ago, depicting a beheaded mushroom shaman, indicating the ritual use of consciousness-altering fungi at least 1,500 years prior to the development of writing. Matthew Salton published a fascinating multimedia piece in the New York Times in December 2017, entitled "Santa is a Psychedelic Mushroom," where he speculates that the Santa Claus legend may have roots in the use of Amanita muscaria mushroom by Sami shamans in Lapland. Maria Sabina was a Mazatec curandera who lived in Oaxaca, Mexico, practiced traditional psilocybin mushroom healing ceremonies. She was visited by a US banker in the 50s who published his accounts in Life magazine. And that's what's been credited with introducing psilocybin to Western society. Bwiti priests in West Africa have used iboga for at least hundreds of years, marking rites of passage, initiation rites, healing, etc. And likely there are many other traditions. And what's clear is that the Western medicalized practices of psychedelic therapy owe homage to a rich and diverse lineage of practices that inform our own syncretic style. So psychedelic therapy in a Western model, it's been going on since at least the 1950s. From the early 1950s until it was stopped cold by the Controlled Substances Act of 1971, there were more than 4,000 scholarly papers and 6 international conferences dedicated to psychedelic therapy. And really, there were too many young people who were taking control of their own narrative back in the 60s, and that was threatening to the dominant neoliberal social order. And that stuff was snuffed out, and there was really a desertification of research and practice in psychedelic therapy, or I should say that that practice went underground for decades. But what had emerged was a model that had borrowed from indigenous lineages and emphasized the kind of the linchpins of modern psychedelic therapy, which is SET, which is the mindset of the client, which is facilitated by preparation, the formation of intentions for the work, the setting, which is the physical environment in which it all takes place. It's supposed to be calm and soothing. Not surprisingly, it doesn't work really well in cold clinical offices. There's a guide or a sitter, which in the Western medical model is typically a psychotherapist or a physician or some combination thereof. And that they practice in a largely non-directive manner of holding space for the client, essentially assuring their safety, providing reassurance during difficult parts of the journey. And then another part of the methodology is integration or post-processing, which essentially acknowledges the need to consolidate the insights that we've gotten from psychedelic journeys consolidate those insights into one's life to move our stories from imagination onto paper, as it were. I'm going to talk a little bit about theories of psychedelic action. This was covered in the Link-Swanson paper and also in the Rebus paper. And I have to say, I kind of apologize for assigning that. That stuff is really dense. Some of it's hard to understand. I'm going to go over it a little bit. Aldous Huxley, the writer, was very interested in psychedelics. He was introduced to mescaline and wrote extensively about his mescaline experiences. his theory of the action of psychedelics was that they act as a reducing valve. In other words, they constrain our sensory inputs into what's evolutionarily advantageous for us to pay attention to. In other words, to facilitate our survival. And psychedelics open the valve to a much broader range of input that's normally outside of what's available to us. And I kind of like this theory because it implies that reality is really much broader and stranger than what we perceive, and that what we perceive is really conditioned by the requirements of our survival. Another theory of psychedelic action is the psychoanalytic theory, which essentially states that psychedelics suppress the ego's control over these what Freud called primary processes, which are sort of woolly and by their nature untamed and nasty, and then we develop these egos that then assert their control over these primary processes, and psychedelics lift the lid on that. The entropic brain theory talks about our brains being balanced between order, or sort of petrification in the extreme, and disorder or entropy. And psychedelics tend to shift the balance towards disorder or entropy. And you can think of that, the entropy is kind of being analogous to the primary process in the psychoanalytic model, and order being analogous to the ego's constraint on that primary process. And think about the ego or the default mode network as constraining the primary activity. And the entropic brain theory argues that the default mode network's organizational stronghold over our brain activity is both an advantage and a source of pathology. And this is from Robin Carhart Harris. It's argued that this entropy suppressing function of the human brain serves to promote realism, foresight, careful reflection, and an ability to recognize and overcome wishful and paranoid fantasies. Equally, however, it could be seen as exerting a limiting or narrowing influence on consciousness. The integrated information theory describes how we create theories of cause and effect in our mind by constraining the universe of possibilities. In other words, we constrain the universe of possible causes according to our prior experience. And implicit in this is a balance between cognitive flexibility and cause and effect information. In other words, if we have really strict ideas of cause and effect, we have less cognitive flexibility. We have more cognitive flexibility. We are more flexible in our ideas of cause and effect. Predictive processing says that the brain is actually an inference machine that's actively predicting and explaining its sensations. The sets of possible causes for these sensory inputs have to be narrowed in order for the system to settle on an explanation. And as a way to save energy, as we talked about earlier, we develop maps of prior constraints or prior explanations as a shorthand to explain the inputs that we receive and to save energy, as we talked about before. And those, what they call top-down constraints, are loosened under psychedelics, which allows for new explanations or new narratives to emerge to explain the sensory inputs that we get. Predictive processing posits that the brain explains self-generated stimuli. In other words, the narrative that we have going on in our default mode network by attributing their causes to a coherent and persisting identity, that is the self, much like how it predicts and explains external stimuli by attributing their causes to coherent and persistent external objects. And again, when that explanation of the self becomes over-constrained, you have depression, anxiety, and OCD. And these become maladies when our self-narratives become too narrow and foreordained. So classic psychedelics in this model work by dismantling these reinforced patterns of negative thought and behavior by breaking down, and again, Carhart Harris, the stable spatio-temporal patterns of brain activity on which they rest. In other words, they smooth out the ruts that we get into, like fresh snow. And you think of the analogy of skiing, if any of you are skiers, when stuff has gotten skied off, there's a lot of ruts, and you're kind of, it's much easier to take a well-worn trail down the hill. But when you get fresh snow on top of that, you're kind of free to go wherever you want. All right, enough of that. MDMA. MDMA is a phenethylamine. It works primarily by releasing serotonin, but it also releases norepinephrine, which is kind of an adrenaline, if you will, dopamine and oxytocin from the nerve terminals in the brain. Because it's a substituted amphetamine, it causes anxiety as it comes on, but that effect wanes over a short period of time, and it opens into other effects. It's known as an empathogen. In other words, it fosters empathy both for self and for others. And some people call it an entactogen, allowing us to touch within ourselves. It extinguishes fear, which makes it really useful for psychotherapy, and it decreases our anxiety and causes mild euphoria. So how does it work in trauma? Used in assisted psychotherapy to reprocess trauma. Brain scans suggest that MDMA create a negative image of PTSD, if you will. In other words, they suppress the amygdala, which is the fear center, and stimulate the prefrontal cortex or higher centers, the planning, analyzing conscious areas. The amygdala lets down its guard. These traumatic memories, which are sort of encoded now, associated with all of this, this additional fear-based information and sympathetic stimulus, reemerge to be sent up for the processing in our frontal lobes that the brain never had a chance to do. And then, possibly assisted by the emotional learning and the fear extinction properties of MDMA, those memories can at last be kind of reintegrated into our brains, into our personalities in a healthy way. And essentially, we create a new narrative about our trauma. And you see a quote here from a guy named Nick Blackston. And this was quoted in the New York Times, although when I was doing my training, we watched hours and hours of video on Nick Blackston. And pretty amazing. He was an ex-Marine who had gotten basically blown up in Iraq. His buddy had died in his lap. He had horrific flashbacks. He had tremendous sense of guilt. He had moral guilt about what he had done in Iraq. He was broken. He couldn't hold a job. He couldn't make eye contact. His relationships were fraying. He was drinking. He was a wreck. And after MDMA-assisted psychotherapy and this protocol, his PTSD was cured. You talk about cure, you really wonder, like, are you selling snake oil here? But there are well researched metrics on scales of PTSD, and people come into these studies with very, very high scores on PTSD, and by the end of the study, by the end of these studies, 2/3 of the people no longer meet the diagnostic criteria for PTSD, and that actually improves over the course of time, over a year. People no longer, 75% of people no longer meet the diagnostic criteria for PTSD. So the effect is durable and improves over time. And this is an effect that is a significant improvement over previously existing therapies like psychotherapy, EMDR, medications. Each of those maybe treats 25% of people effectively, and this MDMA-assisted psychotherapy is at least 75% of people are cured. And the results are so dramatic that in 2017, the FDA granted breakthrough therapy status to this treatment protocol that is kind of the culmination of a 36-year process that's been spearheaded by MAPS, the Multidisciplinary Association for Psychedelic Studies, and Rick Doblin. And I think, as I mentioned earlier, my clinic Temenos Center for Integrative Psychotherapy, which I co-founded with a psychologist, has been selected by MAPS to be one of the first 10 in the country to be able to provide that psychotherapy under an FDA-approved compassionate use protocol. Moving on, psilocybin is a classic psychedelic. It works primarily on the serotonin 5-HT2A receptor. Characteristic of the psilocybin experience is the ego dissolution. In other words, the default mode network is suppressed to the point where our stories about ourselves no longer exist and are no longer accessible. It opens up the potential for a mystical experience. Because our stories about ourselves don't really exist in that space, it flattens these ruts and allows new narratives to bubble up from other parts of our brains to replace these old, tired narratives that constrain us and hold us so deeply in our story. Psilocybin is in phase 3 clinical trials, sponsored by Compass Pathways for treatment-resistant depression and by the Sona Institute for Major Depressive Disorder. And each of those organizations was granted breakthrough therapy status by the FDA for psilocybin for their respective disorders in 2018 and 2019. Moving on, ketamine. Ketamine is fully synthetic. FDA approved in 1970 as a surgical anesthetic. It operates on the glutamate transmitter system, which is the most common neurotransmitter in the brain. It's a very strange drug. At low doses and with certain routes of administration, it can have this kind of MDMA-like effect of extinguishing fear and increasing access to difficult or suppressed memories. And at higher doses and different routes of administration, typically intramuscular or intravenously, you can have these transcendental, mystical experiences that, have all of the qualities of the mystical experience that we talk about before. And we work with ketamine in the office, both in using sublingual routes of administration under the tongue and intramuscular or shots. And we do it in an assisted psychotherapy model with myself and a psychotherapist present. And we've had some pretty remarkable results. Up on the slide is a lovely email that I received from a client along with my co-therapist last year. Ketamine also we know that it has a purely neurochemical effect that's independent of psychological processing. And we know this because we give it to people intravenously without any psychotherapy, and they get better. Their depression, their suicidal ideation gets better. It's also used to treat OCD. It's used in trauma work, etc. Theories of action for ketamine, it promotes neuroplasticity. In other words, we grow new neural connections, new brain connections through the formation of new dendrites in the brain. It also suppresses the default mode network, allowing new narratives to emerge. And it inhibits a structure in our brain called the lateral habenula, which is also called the anti-reward center in our brain. When the lateral habenula fires too much, and we've seen this in functional MRIs of people with severe depression, it suppresses all the reward centers, essentially all of our positive affect. And ketamine actually inhibits the signal that the lateral habenula sends out. So it inhibits the inhibitor of our reward center. So we begin to experience reward and pleasure again. So our model, it's a 3-hour assisted psychotherapy session. We spend roughly 45 minutes in talking, an hour in the medicine session, and then an hour of kind of post-processing as the medicine wears off. One of the nice things about ketamine is it doesn't last very long, so you can do it in a 3-hour session. And then we have integration sessions with people over the next few days. My last slide. So psychedelic experience, in the psychedelic experience, we're really reauthoring our stories. Psychedelics allow us to create or to recreate meaning or to experience meaning in our lives, sometimes for the first time, through the presence of mystical experience. They encourage us to address and not suppress memories that would otherwise be aversive, memories and emotions that otherwise would be aversive. And they allow us to move from kind of an actor reading scripted lines to essentially the playwright of our own narrative. And we have much more freedom and much less constraint under the influence of these substances. And, as kind of occurred to me from one of my own early experiences, I had this sense of coming out of it, of, returning to the sense of joy and playfulness and curiosity. And it really felt like I came out of it thinking, God, remember who you are. So, these medicines allow us to kind of remember ourselves without all of the constraints of our story, without all of the traumas that have been layered onto us that narrow our lenses. Other issues here that we haven't really talked about. There's the use of these medicines for the betterment of the well people rather than treating people who are ill. And there's a lot to be said about that. And then Patricia, I know, sent out the article just recently talking about fun in psychedelics and really the benefits of kind of purposeless play and pure joy. And these are also effects that can be engendered by these medicines. So that's all I got. Thanks.
Thank you so much. Yay. I'm going to let you guys ask questions first. Carl, do you want to call on people? Or yeah?
Oh, no, so that's too stressful.
Okay, sorry. Sophia? Okay. If you guys can also do your hand function, I can see you in a queue too, and write your names down too.
Thank you so much for that presentation. It was truly amazing, and surprisingly, we've discussed some of it in class through our imagination, but it's really nice to know how it actually works. So I had a question regarding how applicable this form of therapy would be for an impaired person, someone who's visually impaired or someone who cannot really hear. I mean, because the entire point is that you need a guide. So have there been any clinical patients that have been hard of hearing or could see? And if so, how effective was this kind of a therapy for them?
Yeah, that's a good question. And I would say that I have not personally treated people who are visually impaired or who are hearing impaired, but I certainly know that there are people who have been through the therapy who have hearing impairment and visual impairment. And there are reports of the therapy being very effective. I've heard trip reports of people who have lost hearing, actually recovering hearing in the psychedelic experience. And I don't know whether it was persistent or not. And of people who have been blind since birth, having psychedelic experiences and actually having the experience of, sort of vision or what the correlate of vision is in their visual cortices. So yeah, it's certainly doable. There are all other kind of manners of kind of rapid healing that are attributed. There's a famous mycologist named Paul Stamets who talks freely about how growing up he had a horrific stutter that made him unable to really talk to people, and particularly in situations where it was sort of a high risk situation, like there was a girl that he liked, he would stutter so profoundly that he couldn't really engage meaningfully in conversation. He had his first psilocybin experience on a massively high dose. And it's a very funny story. He relates it in a podcast that I think he did with Tim Ferriss. He talks about how that experience cured him of his stuttering in one day. So certainly, not everything gets, it's not a miracle cure. I don't want to create the impression that, you have one psychedelic experience and, all of your problems will miraculously disappear, but the effects are, can be pretty mysterious.
Meg?
Yeah, thank you so much for your presentation. And I came to Columbia with like research interests in the health humanities, and I've had some research in 18th century conceptions of the brain, it being this place where the soul can reside, these specific glands where the soul can reside, and being filled with like different fluids and animal spirits and everything. So like that's my knowledge of, of the brain. But my questions actually have more to do with, I guess they're more observations, and then I'd like to hear what you have to say about these observations. But they're to do with psychedelics being, I think Desserteau would put it between like strategies versus tactics. For instance, like you said, psychedelics being this tool that can deliver a lot of relief and care and cure and treatment, but how they can also be used to really impair people and strip people of agency. So I'm thinking of the ayahuasca murders, so of Sebastian Woodruss, and how this Canadian person ended up murdering this shaman of a really of this tribe in Peru, and that having to do with ayahuasca, and then also with ketamine, how you said it's, I think, one of the only legal psychedelics, and the COVID Black Lives Matter documentary that Professor Dailey had us watch, I think, mentioned that the death of Elijah McClain, part of that, it had to do with, Elijah really being impaired by ketamine, and how that really, really took away his agency and his ability to really function. So like I said, it's not really questions, right? It's more so just thinking about how, these tools, I guess, very much are tools, and they can really be used to harm a lot of people. I think especially because they have these chemical properties, right? But then also because of like, cultural appropriation and other kind of significance.
Yeah. Yeah, no, thanks. Those are important observations. And the medicines themselves can be misused, and this is why there's so much emphasis on intention setting and setting. There's an old saying that the difference between a medicine and a poison is the dose, in one sense, right? And in this context, there's also how the medicine is being used, with what intention it's being used. You point out Elijah McClain, that was an instance where ketamine was used as a tool of control. It was used as against his will, intrusively, and that caused tremendous harm. It caused death, and that is very, very serious. And that's one of the reasons why there was such a huge uproar in the psychedelic therapy community about that, because we really see these medicines as being almost sacramental in the way we use them, and to see them kind of profaned in that way as a tool of control is incredibly distressing. Similarly, you see this in other contexts too. I mean, this has happened in one of the MDMA studies. One of the therapists got sexually involved with one of the clients, which is just a huge, bright line that got violated there, and that was really distressing to so many people, because it was felt to, there's so much there was such a huge backlash in the 1970s that shut this all down, and people that do this work with integrity and with the intent of creating a really meaningful therapeutic container have sort of clawed their way back to this place where we are now, sort of perched on the ability to be able to legally use all of these medicines, and to see them being misused creates this fear of a backlash, and we're going to lose what we've gained. So all your points are well taken. You also see medicines being misused by shamans, and you see this in the particularly in the 5-MeO-DMT community. People that enter non-ordinary states of consciousness are vulnerable, and unless there are impeccable ethical standards to go along with this, it's dangerous. So.
Thank you. We have first Connor, Ashley, Safia, then Mikra. Oh, and then Alina. Okay. Sorry. These were the hands that came up in their order. Sorry. Mikra, then Alina. So Connor?
Yeah, I just want to echo what everyone said. Thank you for that incredibly informative presentation and talk. I was curious to hear a little bit more about what the post-processing phase of the trip looks like, and how, I guess, like, the experiences that the person, who's taking the trip has, how they become narrativized or maybe re-narrativized and sort of incorporated into this new idea of the self after the trip. And I'm also curious about the mediator's role in that authorship too. So just hoping you could speak a little bit about that, or maybe about an experience you've even had if you've played that mediating role yourself.
Mm-hmm. Yeah. So I want to start off by saying that I'm not a psychotherapist. I'm the medical doctor, and I'm trained in the specific techniques of psychedelic therapy, which are largely non-directive. In other words, during the experience, for the most part, you're not steering the client in a particular direction. There's a feeling that there's an inner healing wisdom, that there's a psychic intelligence that comes up, facilitated by the medicine, that takes us where we need to go. Unless somebody is not much content is coming up, or people aren't going in their journey where they talked about wanting to go before their journey in their preparatory sessions, we'll mostly leave people be. But if somebody's just sort of going off on a tangents that are completely unrelated, or not, clearly not dealing with the trauma that they wanted to deal with, then we'll sometimes gently remind people of where they wanted to go. With respect to the integration, it really depends on what materials come up for people. Sometimes the client will have imagery that comes up, and they will talk about that imagery a little bit, or they'll say what that imagery is in their session. We'll write it down. We'll reflect that back to them in the integration session. That then, because they might have forgotten some stuff, might then trigger memories, which then allow them to kind of re-experience what they experienced, which allows them to integrate. And some of it is that people are people in the immediate post psychedelic state are suggestible and kind of porous. So it's really an opportunity to help people remember what they saw or what they experienced, and to kind of firm it up, to integrate it, to to reiterate what they've experienced, so that they can move it into their kind of working consciousness. And for a lot of people, it's not a one and done thing. This is for many people, it becomes an opening to an ongoing psychotherapy that they then have material to work with, and they have kind of openings into stuff that they hadn't seen before. So it becomes part of a process that way.
I think after Connor, we have Ashley.
Yes, so thank you so much for the presentation. Something that I've learned in our readings is that one's set and setting can have, a really big impact on the psychedelic experience. And one of my concerns about psychedelic therapy is that one can potentially have a negative experience, maybe if their temperament isn't well suited to it. So maybe they're like nervous or they're scared. I'm not exactly sure what would cause a negative trip, but I'm wondering if this is a problem that you encounter, and if a negative psychedelic experience could have, lasting effects that are counterproductive to the treatment of trauma.
Yeah, really good question. Psychedelic experiences can be really difficult. And difficult experiences are not necessarily bad experiences. Difficult experiences of reprocessing traumatic memories, of revisiting hurts, can actually in the long run be profoundly psychologically liberating for people, even though the experience itself is really painful. I've had people scream, cry, weep during their experiences, who later felt real gratitude for the treatment. A lot of the adverse experiences that, the quote unquote bad trips that people have, some of that is preparation. A lot of that is preparation. So, before set and setting comes preparation. The idea that you are preparing people for stepping into something that's unknown. You don't know what's going to come up. You don't know how much of it's going to come up. You don't know the content, what the affective coloration is going to be. Is it going to be joyful? Is it going to be sad? Is it going to be frightening? And we encourage people to approach the experience with an attitude of openness and curiosity. Things that are scary in your psyche, we want to know what they're doing there, because they have a place. They're there for a reason. They've shown up there for a reason. So, move towards the scary thing. If there's a door that's closed and it looks ominous, move toward it. What are you doing here in my psyche? So the preparation is really important to redirect people who might be having difficult experiences to the kind of the positive aspects of those difficult experiences. There are certain people that shouldn't have psychedelic experiences. People with psychotic disorders, people with severe personality disorders, thought disorganized, who have kind of intrinsic thought disorganization, probably are not going to be helped by the increased, randomness and entropy in their brains. So some of it is client selection too. It's not for everybody. It takes a certain it takes a certain degree of preparation to be able to do it.
Safia, then Mikra, Alina, then Grant.
My question is very similar to Ashley's, but I just have a follow-up question on how do you diagnose someone if they don't have a diagnosis? And another question would be, does this work on patients with schizophrenia? So if I'm to come to you and I have some disorder that makes me not so perfect for the experience, is there a way that you can figure out that, okay, this is not something that I'm not fitting the profile?
Yeah, so let me take the second part of that first. The schizophrenia is a no for for psychedelic therapy. We talked about the overly constrained brain being what you experience in depression and anxiety and OCD. In some ways, you can think of schizophrenia as being an under-constrained brain, where it's more on the scale, if on the ossification to total chaos side. The people with schizophrenia have brains that are more chaotic, and the experience of suppressing the default mode network to introduce more entropy or more chaos into the system does not work for those people. And so that's sort of one of the hard rule outs for psychedelic therapy. Remind me the first part of your question.
How does one gauge how if I'm a fit for the experience, if I'm not aware of my diagnosis myself?
Yeah, honestly, diagnosis is overrated, and it's a game that we have to play. And it's one of the artifacts of lodging psychedelic therapy in a Western medical model is that you have to play this game of diagnosis, and you have to pathologize normal human experience. And, people experience grief, sadness, depression. It's all on a continuum. If it becomes, extended over in a longer period of time, you say somebody's depressed. If they have symptoms that impair their ability to function, they're depressed. But really, who can't say that that's true of themselves at some point or another in their life, right? I mean, we all have experiences that are difficult. We all have profound sadnesses. We all have extended periods where we've experienced, things feeling difficult and we can't get out of our heads and whatever. And this, this is, I kind of alluded to this a little bit at the end. This is where you talk about the betterment of well people, right? Is it ethical? Is it legal? Is it ethical to give psychedelics to well people to feel even better? In my ethos, it is. Is it more important for the therapy, for people who are severely depressed or suffer from severe anxiety or PTSD? Probably. But I don't think I don't think it should be a requirement that you have to have a diagnosis to go through this.
But the reason I ask that is because, and I'm sorry, it's my last question. Have people who probably engage with a psychedelic experience, have they slipped in psychosis because of a bad trip or something? Have there been a few cases in which the patient walked in and experience went so bad for them that they just lost
that's a good question. I mean, I think and I don't know the literature extensively. I think that the answer to that is that people who are tripped into psychosis by the psychedelic experience probably have a latent psychotic disorder that is not yet manifest, and that people whose brains have kind of normal architecture and sort of normal variant chemistry would not be tripped into that. Ketamine, if people have undiagnosed bipolar disorder, ketamine has also been reported to trigger people into manic episodes. So we sort of, you screen for that ahead of time as best you can.
Mikra, Alina, Grant, then Robert.
Yes, hi. Thank you for being here, sir. My question is more about, you mentioned something in the beginning about the nature of consciousness. And my question and my interest is more about how the psychedelics, as it is right now, what the thoughts and scientific ideas are about how psychedelics are helping us to understand the rise of consciousness from the traditional model that we understand that rose from physics and biology. I mean, part of the reason why I became interested in this particular aspect of literature is there may be a couple of books that I was very influenced by. One of them is Mind and Cosmos by Thomas Nagel, the famous author who wrote What Is It Like to Be a Bat, that essay in the 1970s. And the other book is The Meaning of Human Existence by E.O. Wilson, the biologist. So anyway, both of them touch on this idea that E.O. Wilson says that at the end of the day, the scientist thinks like a poet, in a wide-ranging, fantastical, those kinds of things. Everything is at play here. After a lifetime of studying biology and organisms and reductionism in a sense, he comes to the conclusion that it's imagination that matters. You know, it's all these sort of like fantastical ideas and otherworldly thoughts that we have that matter, and how we go about and discover our own process of consciousness. In the same manner, I mean, Nagel speaks about how it's difficult to understand consciousness by the process of reductionism, because we don't really know how consciousness arose from the physical process. We don't have an answer to that yet as of now. And I'm always interested in the way how psychedelics, this potent concoction of chemicals or whatever of nature, actually helps us understand this particular intricate problems or any, in a way, like reorganizing our thoughts about how to think about consciousness from a physical process, if that makes any sense.
Yeah. You know, what comes to mind is really the question of whether consciousness arises from physical processes or almost the other way around. And you know, as I gave a few references for readings in this area, and it's an area that really fascinates me. And it's an area where kind of ancient, inward-looking wisdom traditions have illuminated the nature of consciousness in a way that correlates with emerging findings from neuroscience and quantum physics. That's really intriguing. And you know, it speaks to the idea of consciousness being a non-local phenomenon, meaning it's not something that's necessarily lodged in our brains. And you know, and what that means. And it also speaks to the idea of consciousness that our consciousness can persist in a way beyond our own death. So, you know, these are really, you know, in some ways they're really controversial issues. I think they're really fascinating. And, you know, if one, I think if you use the idea that psychedelics kind of can pull back a veil on a different nature of reality than the one that we inhabit in our day-to-day lives, the psychedelic experience can be a complement to the kind of the consciousness exploring wisdom traditions of the East in elucidating the path forward. And there are a number of really prominent neuroscientists and physicists who feel that the next, you know, big wave in the next scientific revolution, which is going to be akin in its kind of paradigm busting nature to the Copernican revolution, is the consciousness revolution. This notion of consciousness as being kind of primary stuff of the universe. So,
Thank you.
Alina, Grant, then Robert.
Hi. Yeah, so I actually think you probably have touched on this throughout your answers a little bit, but I was wondering about whether there's much data about the kind of lasting effects or how lasting the therapy is, because one of the things that's true of depression and anxiety is that these are often things that cannot be cured quickly or often at all, that people must live with continually. And it's often the thing that we'll struggle with, that it's not something that, they can, go to therapy for 6 weeks for and get it sorted. And I wonder what effect it might have, the kind of transformative promise of psychedelics, or like a trip where once you come out of it, the first, in the first maybe few months, you might feel, transformed, or you might feel better. And then what happens when, say all the conditions of real life that the Horizons documentary touched on, or just like in general, your life starts to reassert itself again?
Yeah. As to the durability of the effect, it can be really variable. It's dependent on the individual. It's dependent on their experience. I think it's dependent on how much integration has happened, the quality of that integration, dependent on the medicine. We see people, because I'm most familiar with it, with ketamine, who experience a tremendous improvement in their depression as a result of the use of ketamine, and then we'll start to slide back a little bit. And then those people come in for boosters every so often, every month or couple of months. Whereas for other people, the effect is more durable. Some of it is really, the durability has to do with what the client comes into the experience with, and what they're struggling with. For some, the issues are really rooted in people's biography, and for others, the issues are sort of psychospiritual. And if you come in with sort of a spiritual deficit and have a full-blown mystical experience of unity and oneness and God, that can last people a lifetime. And you see this from the near-death literature too, that people have these experiences. And for other people, it doesn't last forever, and needs to have more work done, and life intrudes back on your happy bubble, and you start feeling the feelings bring you down again. And with many people, they have some tools in their tool chest that makes it easier to work their way back out of it. But it's not a magic bullet for most people, and you are susceptible to the vicissitudes of life and relapse and all of those things.
Grant, Robert, then Aisha.
Yeah, so I guess a lot of my question has been touched on with other people's, so I guess I can make it kind of a two-parter. I was kind of curious how your clinic's work fits into longer-term care, particularly like major depressive disorders and stuff like Alina said, can't be cured like outright, or at least we know can't be cured outright. And what you think of like people microdosing on these substances, like ketamine microdosing and like LSD microdosing.
Yeah. So at our clinic, we insist that most, if not all, of our clients be in a long-term psychotherapy, or at least an ongoing psychotherapy, not necessarily long-term psychotherapy. What we do is kind of its nature more sort of short-term, and we interact with and talk to client psychotherapists to kind of hand off the insights and the work that's been done, so that it can be picked up in their work with the therapist. So that's how we handle the kind of the short-term, long-term part of the question. The other part has to do with microdosing. there's a lot of people that are big proponents of microdosing, and the definition of a microdose of a medicine is that you take a small amount, typically 1/10 or less of the active dose, so that the effects are subperceptual. In other words, you don't get any alteration in your perception. You're not tripping. You're not aware of having an altered sensorium. And a lot of people describe that it helps with mood, that it helps with creativity, that it helps with energy, that it helps with social anxiety. I mean, all manners of stuff have been attributed to microdosing, and by far the greatest microdosing. Call it search, not research, because that's the term that James Fadiman, who's the guy who's been doing cataloging of this work over the last couple of decades, that's the term that he uses. The most of that has been done with classic psychedelics, LSD and psilocybin. I don't know much about ketamine microdosing. I know people use it in small doses for things like chronic pain or so on. I don't know about using it in subperceptual doses. But I would refer you to, I think it's called microdosingpsychedelics.com for more information about that.
Robert, Aisha, Chris.
Yes, you talked a little bit earlier about setting and preparation. What sort of concrete steps do you ask your patients to take before a psychedelic experience? Do you ask them to write down their goals? And if so, to what level of specificity do you ask them to think about what they want to work on and things in that?
Yeah. So, there's a difference between sort of setting an intention for the work and having a wish. A wish is, I wish to be free of all my depressive symptoms. Intention is something like, I want to be open to seeing the patterns in my life that have held me in difficult relationships with people over time. So one of the ways that we encourage, that we set the set, if you will, is to encourage people to think in terms of intention for active work rather than wish for passive receiving. It's important that people journal, that they spend as much time as they can afford to spend in really kind of preparing themselves for the experience. To really, this works best with people who are already psychologically savvy. And I'd say, and I don't mean psychologically savvy about other people, but I mean who have done a bunch of their own work to kind of understand how their own psyches work, so that it's more of you get more of a shorthand when you get into the psychedelic experience, because you sort of know how things, how you're organized in a way. Although it can work for people who are less psychologically savvy as well. So doing that degree of preparatory work is important. Everybody comes into the experience anxious. And I get a little anxious if somebody says, no, not worried at all. You're stepping into something that's mysterious. You're stepping into something that's non-ordinary. You're stepping into something that has the potential to be terrifying. You're stepping into something that has the potential to be beautiful, and you just don't know. So, who wouldn't walk into that experience and be a little bit scared? So bravado is a little bit of a red flag for me in this work. Did I answer your question? Are there other components to it?
Absolutely, you answered it totally. Thank you.
Aisha, then our last question will be Chris.
Hello. Thank you for the brilliant talk. So I was wondering that dreaming is also a kind of situation when people don't really have as many inhibitions operating at that moment. Um, and often in dreams, we tend to go back to a traumatic experience as well, repeatedly or more than once. Um, and and most of those times, if it has been a traumatic experience, it doesn't really make us feel better by facing it again and again. So I understand that during a psychedelic experience, there's something that will activate the serotonin. So it will associate a kind of happier feeling while perhaps I face that same experience. But I'm just wondering as to the nuances or the differences of of facing the fear, of facing the trauma, and how is it that facing it this one time or these 2-3 times is this so different that it stops being traumatic for me. For example, somebody's death happens and it keeps coming back to you because perhaps you were involved, not in killing them, but towards the end. So it also leaves a mark. So I'm just wondering as to how the facing your fears, because if there was something that would say that forgetting, I don't know, as a person it would make me more comfortable for trying to forget something instead of facing it. It might also have to do with my own control issues. So that one, and a very small question that, so every time there's something which is related to the psyche, say hypnosis, there's always these questions that maybe the patient was also lying, or maybe they cook up something to make the experience sound more than it is. So if those kind of experiences have happened. Thank you.
Mm-hmm. Yeah. So starting with your second question, I don't know if patients have lied to me. I don't know how I would know. The people come to this typically because they're suffering. People come to this paying a lot of money for the experience. People come to this with hope, that sometimes desperate to feel better. So the incentives to fake it are small. So I haven't, I don't know if I've encountered that. As to the idea of dreaming, Freud called dreams the royal road to the unconscious, and he actually was kind of dismissive of psychedelics. The thing about dreams is, and particularly you go to a Jungian analyst, and they're all about your dreams. They want you to write down your dreams, but really, do most of us write our dreams down when they happen, and wake up in the middle of the night and put them down? It can be really hard to actually do that. But when done, not necessarily, reporting a dream that I think you're describing as one more of a flashback of an intrusive, painful memory. That's more akin to a flashback, that type of experience that people have in post-traumatic stress disorder, where they keep reliving that traumatic experience and they keep getting re-traumatized. So that is a sort of a subset of dreams that is that I think of as being more in the realm of re-traumatizing versus producing some symbolic imagery that you can use then with your therapist or your analyst to help unlock some other psychic material, right? As to why the processing of it during, and for example, an MDMA session can lead to extinction of that of the re-traumatizing nature of it, rather than it being re-traumatizing in and of itself. That's one of the great mysteries that I threw out one of the leading theories for how that works. in that under the influence of the medicine, your fear is extinguished. You have tremendous empathy for yourself. You have empathy for others. The limbic system, that fight or flight response, is quieted down. You can bring this memory back up into your consciousness. You can look at it. You can see it. You can have empathy for it. You can have empathy for yourself in it. You can feel grief, all of these things. And then the memory goes back down and gets reprocessed in a way so that it's stored. And it's not like it gets robbed of its impact. It's not like it's stored, like a trip to the grocery store. I mean, it's still a traumatic memory. But what that seems to do is it seems to avoid re-triggering that sympathetic nervous system activation that comes along with it, that fight or flight response that comes along with it, the terror that comes along with it. And it seems to reduce the frequency with which those memories then re-enter our consciousness and present themselves as being intrusive.
Chris, last one.
Yeah, thank you so much for that presentation. I thought it was really exciting. My question is sort of, I'm used to thinking about experience and the way we constitute meaning as sort of lagging behind our sensory input is how I've always thought of it. And so what was so exciting to me about your presentation is that especially predictive processing theory sort of seems to flip that. And there's a way in which, these patternings and these probabilistic predictive ways of thinking seem to sort of like keep ahead of sensory input and bottom up raw information that we're getting. And how the psychedelic experience seems to like enact some sort of possibly, can we think of the shift or alteration it enacts as in some way temporal, in that we're like no longer trying to be ahead of what we're experiencing in some way? And then I guess, is that, if you can describe the psychedelic experience in some way as a temporal shift or temporal alteration, would that be therapeutic, do you think? I know that's like a very broad question.
Mm-hmm. Yeah, it's interesting. I hadn't really conceived of it before as being a sort of a temporal shift. Insofar as anticipation is a temporal shift, right? And our anticipation can be affectively colored, right? You can anticipate something with dread, or you can anticipate something with glee, right? I think my personal experience of the psychedelic experience has been that it enables me to tone down the anticipation of bad things happening, right? The anxiety, like, oh, shit's around the corner and it's going to go down, right? And now there's less of that becomes less of a kind of an intrusive awareness, and how that relates to kind of reset, weighting of my priors in my brain. I don't know. That's speculative. But I will say that I think that you're, without really sort of knowing the answer, I think you're onto something in terms of kind of flipping the temporal relationship between cause and effect in psychedelic space, and what happens after psychedelic space, and how we process information.
Wow, this has been so wonderful and helpful and informative. I think we will have the substance for a lot of discussion in the future. One thing that I just wanted to share with everyone in terms of thinking about the relation to the seminar too is how it's so interesting, Carl, the way that you position psychedelic experience in relation to religion as a kind of, affiliated but interested in different kinds of noetic experience, so to speak, and is very similar to the way that literature is described by Derrida. So if you guys kind of can see this as a similar genealogy in the way that these are, conceived of in that way. So I just want to put that out there, but also the way in which the mysticism and literature both harbor this kind of secret, and the secret or mystery that is related to noetic experience. And we can talk more about this at a future date. I think Deleuze, Chris, talks a lot about the kind of the temporal inversion, especially in relation to cinema. And I signed that introduction to the book on Deleuze, altered states and cinema too, which might be interesting to you in terms of the way Deleuze thinks of time too. That might help, and help us understand too the relation to psychedelics. So I'll stop there. Thank you so much, Carl. I think a round of applause. Thank you for your incredible elucidation and concise and capacious understanding of the field and beyond. It's really, really helpful for us to get a broad spectrum kind of and understanding its translatability too into all these other different kinds of registers and fields.
Thanks. It's been really, it's been enjoyable to be here. Really, I've had fun, and I hope that it ties into what you all have been working with this semester. And yeah, take care. I'm going to drop off.